So welcome everybody. This is a very informal discussion, question and answer session about new service models and what we can take from the service developments that have emerged in the last 3 months and hopefully transform MS services going forward. So I would just like to welcome my guests today. Alyson McGregor, who's the National Director of Altogether Better. Alyson, you would like to say a few things about yourself?
Thank you, Gavin, happily. I'm the Director of Altogether Better. We are an NHS national network organisation, and our work is around bringing people in communities, citizens, patients, together with the people who deliver services to work on the things that matter. So the work happens in that place where we realise that there are some things that we can only do together, not on our own. And I think that what's been happening during the emergency has been a really good example of why we need to work better together and not in our individual places and in our individual silos. We do this work across the country in all sorts of different settings, predominantly at the moment in general practice, but also in acute settings. But really interested to be part of this conversation. So thank you.
Thank you, Bernie. So Bernadette and I go back many years when she was a nurse consultant at the National Hospital. She's now taken on a new role. So Bernie, your role today is about your new role. So you want to tell them what you're doing with NeuroResponse?
Okay, so I set up NeuroResponse as a digital care model to improve out-of-hours care for people living with MS and other long-term conditions. I'm doing that as part of the NHS Innovation Accelerator and the Clinical Entrepreneurship Program, which is encouraging clinical staff to, turn ideas into reality. That's what I'm doing.
Thanks, Bernie. And then Amy. So Amy's a nurse specialist from the south of England. You can see she's got a fantastic suntan, which is. So Amy, you want to just tell the audience about who you are and how you work?
Yeah, so my name's Amy Harbour. I cover South East Hampshire. I am primarily community-based, so we cover about 150 square miles as a community, and we have 5 community hospitals which we support.
Thank you, Amy. And then George, everybody knows George. So he's the founder of Shift.ms, and he has MS himself. George is based in Leeds. George?
Yes, the Shift.ms is focused on supporting people with MS who are recently diagnosed. It's a web-based service, and it's all built around kind of peer support and lived experience. As Gavin says, I live in Leeds and have been diagnosed with MS for over 15 years now.
Thanks, George. All right, so there's little doubt. I don't think anybody who works in the MS service provision has noticed that COVID-19 has turbocharged changes in NHS. It would normally have taken, I'm not joking, decades and sometimes more than decades to implement. So maybe I should start with Amy on the coalface. What has been your experience over the last 3 months, Amy, in Hampshire?
I think it's probably the same everywhere, really. We've kind of gravitated towards technology. So video clinics, telephone clinics, which we've used for all of our clinics. So whether newly diagnosed, relapse and remission, possible relapse management. So when this first started, we were redeployed. So it was, first of all, we stopped our clinics, but bringing them back in, we've started with the virtual clinics. And actually what we found is that the length of time for the clinics have shortened since we've started doing them virtually. Whereas when we were doing face-to-face, it would take approximately 30 minutes. Whereas we're finding now that they're taking between about 10 and 15 minutes. I don't know whether that's because we've given people the chance to self-manage for quite a short period whilst we were deployed. So they've kind of found the tools and techniques to do that, or whether they feel a bit more comfortable because, I don't know, if it's a telephone clinic, for example, that they don't have to go and they can kind of cut the interview short and say, time for me to go. So I think that's probably the main one. And what that has meant, like I said, I was community-based, so our clinics can take over an hour to get to, and that's with good traffic. So that's 2 hours a day that we're not travelling. So within those 2 hours, we can do a lot more, whether it's patient-related activity or whether it's research. We've got a lot more time that's free. So I think that's probably been the same talking to other people and other professionals that we've seen mainly. So it's, all virtual. I think as MS, or in our team specifically, we have been using social media platforms to communicate our latest information that's either been brought down from the government or whether it's local information. Whereas before we were sending information out via post, which obviously takes quite a long time. We've got about 850 patients within our caseload. So we kind of encourage them all to start following our social media, which has got a good response actually.
So which social media platforms are you using?
Well, we've only just started with the Facebook. We were a little bit Twitter naive, so I think we'll just need to start using that a little bit more as a trust.
Okay, so let's now go to George. George, you're a person with the disease. What's your experience been? Have you had to interact with your service over the last 3 months?
Yeah, I haven't had any scheduled appointments over the last 6 months personally. But from those I've spoken to in my area, the kind of remote access to healthcare professionals has been a bit of an eye-opener. For many, and very much me included, kind of remote appointments weren't even an option before. And it's kind of, I suppose it's forced the hand of departments that were perhaps previously very resistant to change. So that's certainly a major plus. I think other good aspects are the video calls between healthcare professionals and patients. I've had a number of people report those as being a bit of a leveler. It kind of removes some of the top-down aspects that kind of exist in kind of in-person clinic appointments. As Amy's saying, it can be more efficient. So less hassle from a patient perspective in terms of kind of travel stress that can exist. I've also heard major pluses about kind of support partners also being able to attend remote appointments and kind of the support that brings to the patient. So that's a very good thing. I think just generally avoiding unnecessary hospital visits has been a plus, and that's obviously been really stressed throughout the pandemic. I think remote appointments also, or video calls at least, give the healthcare professionals the opportunity to see their patients in their own environment, where they may gain a kind of a rounder picture of the patient's life and potentially the challenges that they face, which may or may not inform kind of the advice and support they offer their patients. And then with kind of the added context of their home life, perhaps more focus can be placed on how the healthcare professionals can work with and can empower their patients to take a more active role. So they're kind of the pluses. There have been some less good aspects as well. I've heard quite a large number of people who have had remote appointments have been via telephone as opposed to video call. And perhaps that's not as ideal, as I think some report it being kind of more detached than what a video call experience can bring. There's, I suppose, the inevitable technical issues that can come up, but hopefully that's more of a teething problem and something that would last longer term. I think remote appointments do have their limitations, but what I have heard is that a lot of even physical examinations can be done in some respects remotely. I've been hearing about how EDSS examinations can be done at a pretty decent level. I'd be interested to hear from other healthcare professionals about that. And I have also heard that some talk of kind of the in-person interactions that are experienced with hospital appointments, that there's perhaps particular concern about those who don't have a support network. So if you don't have a support network, not having an interaction with others and just going straight into a video call or a telephone call, that might, people who live alone may be missing out something there. But it seems actually there's been some real positives that have come over the last few months. I'd be particularly interested to know if non-attendance differs at all from in-person to remote. I'm not sure if anyone on the call has any thoughts on that.
Well, I can tell you my experience is we get the either MS nurse or my secretary to our pathway coordinator, we call them now, to contact the patients and warn them. But even then, we still get some non-attendance. But I've even had consultations with people in Hong Kong, in Saudi Arabia, in Paris, in France, because there is no geographical boundary where these patients are. All they need is their mobile phone with them, and you can have these appointments. That's that's the advantage. There are no geographical limits, I must admit, from a neurology perspective, the boundaries have fallen. So I've never had so many emails, even Twitter messaging, or somebody who's got my phone number will just WhatsApp me. So I think that's the boundaries of how to contact your healthcare professional have fallen apart. So that's from a personal experience. Bernie, because you've been on both sides of the fence and you set up your NeuroResponse almost a decade ago, do you think these changes are good?
I think some of them are good. Obviously, I like what George was saying there, and I've heard this recently in the last few weeks about how the video conference calls is a leveler. You know, one of the people that I was talking to said, oh, and the consultant even introduced himself with his first name, you know. And but it was, you know, and that was, but it was the humanity, and this, isn't it? It's a bit perverse that we're in a world where we're using technology, but somehow there was something more human, and it seemed as if more even in the relationship, and so that was something that's come through. I've also heard people say that, you know, if you're offering remote only options, people, you know, not liking it. There's value in going to your centre. There's value in face-to-face seeing the team. You feel that sort of link with your community. So I think going forward, there'll have to be a balance of both. Some of it's good, but we should be careful not to, you know, lose the humanity and the human contact element. And I would imagine, Amy, it's like that from you know, a nurse or, you know, perspective as well. There's, you know, there's so much you can do, but there is also other things that, you know, that build relationships. So I think it's a mixed picture, but I'm absolutely delighted that you know, that the neurology world and the MS world has embraced these solutions, because the concerns I had was when some of them, you know, what Trish Greenlaw would call eminence-based medicine, you know, suddenly the evidence was out the door, and they knew, you know, people said you can do this, you can do that, you can do the other. Then suddenly, you know, everything changed, and I just felt that it was a bit unfair for people with MS. The world was feeling vulnerable, but our population was sort of told, oh, go and self-manage and keep an eye on yourself, and, you know, whatever. But we weren't very good at preparing people to do that. And at one stage, it looked as if we were going to turn our back. But, you know, thankfully, we did embrace the technology, and we've opened a new way of doing things.
So let's move to Alyson. Alyson, I mean, obviously there's some very good things that have come out of this. So now what would you recommend we do going forward post-lockdown to keep these embedded in the service, in the NHS?
I think that what we've seen happen has been absolutely fabulous at some levels in terms of the barriers that have been broken down. And I definitely think that being connected by video, particularly by video, it does the things that Bernie talks about in terms of changing the relationship. And there's something for me around, you know, if we want shared decision making to be something that's important in this work, then there's something about that power balance between clinicians, and just that very simple thing, somebody introduces themselves by their first name, or you're coming into my home. So I think it makes people behave differently. I really like the idea that there will be things that will continue to happen where it works for people. It may not always work for everyone. I think that one of the other things that we have seen happen is that because people have had to learn to become connected who might not have been connected, we've seen the generosity of people in community, neighbours, friends, volunteers coming forward to help people to become connected. You know, so somebody on a telephone to somebody, helping them to work it out on screen and work out how they make a connection and handhold them through that first one. And I think that there's been something really lovely in how we build connections, how connections have been built between people. So I think the more of that, that's not about a service who sees itself as providing everything, but as a collection of people who work out what is it that we need to do together to continue to do this or make things work. And I think that there's been just such lovely stories of those things happening, and the confidence that people get. And we work with a lot of older people in primary care. of becoming connected. So it's not just connected for the appointment, they might then be connected to their family who they don't see in other parts of the country. So this is personal, but my mom now speaks to me every day and she sees me, and it matters in a different way to the way that we communicated when we were. So I think there's things that have come out of this that we should continue to hold close and dear. I think the other thing that struck me was there are some things that have emerged. You talked about the breaking down of boundaries, Gavin. We've seen a lot of health professionals start to use things like WhatsApp rather than formal email and communications. It goes into the box, you don't get to it for a week, but WhatsApp being a much quicker way of turning things around. But it's also a place that's operating in a sort of more of a liminal space and not as formal a space. So we've seen relationships develop quicker between people, and we think that that's a good thing. So there's some of those things that we would want to see continue. And I think that the final thing possibly is that if we are connecting people and appointments are taking less time, maybe there's more capacity to do some other things. So to actually find out things that we might be able to do that connect people into other support other than the clinical support. So the main relationship between the patient is with the clinician, but how do we connect them into each other? I talked to a woman during the week last week who has set up something called a virtual chatty cafe. It's not to talk about the disease. It's not about education. It's connecting people up who are in that isolated group, shielded group, not out and about, and they just get together virtually. Somebody hosts it. It's a really simple idea. And we know from talking to patients and from the data that people are isolated. So how do we connect people together? So I think they're the things that we would really like to see continue.
I think there's a real opportunity here for the MS, well, for the general community to research this, because at the end of the day, we do need some evidence to support at least the funding of this, or the continuous funding of this going forward. I can see the NHS closing down, wanting to close down this because we haven't got the evidence. Amy, is there anything you're going to keep going in terms of, it sounds as if you're not going to go back to the previous service model. You're going to adopt at least a hybrid model going forward. Is that correct?
Yeah, I think that's correct. And it will differ depending on who we are seeing. And so, for example, newly diagnosed patients, I think that these are an area that have found it quite tricky during this period. Whilst I think a lot of the technology is good and it's nice, there's something about either them seeing a doctor in a clinic or an MS nurse going to their home, or for them to come to clinics just to get an overall view of how they are. And personally, this is, not speaking for everybody, but I always like to see somebody who I'm going to have a relationship with for a long time, so then I can assess each clinic, how they change or how they differ. And speaking to the MS Trust, their feedback is that people with newly diagnosed people have suffered through this term as well. So I think a lot we will keep. So a lot of the virtual clinics we will keep, and we are actually pushing people more towards social media as well. And I was going to ask you, George, have you found any more increase over the last couple of months on your platform?
Yeah, so in March and April, I think there was definitely significant increases both in traffic in terms of interaction between members. That's kind of reduced. I think there's COVID fatigue across the board. I'd be interested to hear your thoughts. I think the frustrations that we've heard from people who are newly diagnosed are the kind of delay in actually formal diagnosis and the delay in kind of the follow-up appointments that would usually happen. But actually, again, going back to the kind of video call versus telephone, I think it's important we don't class those as the same. And I think telephone appointments are not good enough. And where at all possible, where physical appointments aren't appropriate, then video calls should become the norm.
Yeah, so one of the problems I have with this is my wife now works in education, but there's such a big digital divide that's driving up inequality, because some families just don't have the technology or the Wi-Fi connections or the computers, etc.
Yeah.
And so those kids are being disadvantaged to kids who come from more affluent environments. And I've actually seen the same thing in my area. There are some people who don't have smartphones; they just have old-fashioned SMS, phones, and you just can't do video linkage because the technology I use is the AQRX platform, which requires a smartphone. So that's something we, at a government level, have to be addressed as policy. We have to actually. Jeremy Corbyn had this idea of making broadband utility. Everybody should have access to a national broadband network, and I'm beginning to realise if we want to equal, make the playing field equal, we're going to have some kind of political will to do that. And we should also say that everybody needs a smartphone, because if we're going to access services via smartphones, then everybody should have a smartphone. Everybody should be educated to have a smartphone.
And that was something that was picked up years ago. But you'd see Deborah Miller in the group in the Cleveland, because there is this issue about inequality. But you're right in that, that we should be, as part of the assessment, if people are unable to, be connected, then there should be some central funding for that, and to get some equity into the system. And I think that one of the steps we're going to have to keep going is more population health, approaches, which will try to challenge us to reduce that variance. But back in maybe 15 years ago, when Deborah Miller, you all know, is the prof of psychology at Cleveland, has led a lot of work in MS, but they worked out for their telemedicine issues with their most deprived and disabled group that it was cheaper to pay like $500 and connect them up at home through their insurance system than it was to keep bringing them over and back to the Cleveland. So I think we should look and see other areas who've done things like that and take and maybe champion some of the things that the charities should do, championing that type of equity in the system.
So if we're saying that healthcare is a basic human right, and we're now going to deliver it via technology platforms, then the technology platforms have to become a basic human right. Alyson, what would you think about that, Alyson?
Well, I was just going to say we are working at the moment with partners in Southwark, and I think this is why we need to work together as a whole system, not just health, not just one part of it. And what's happening in Southwark is that they're supplying the kit, smartphones, ability to get online to many people. They're talking in hundreds, and they're obviously talking about using that data that they've got to target people who most need that kind of service. But that has happened. I read in the report 800 devices have been given out to people, and this is so people could be connected, could stay connected. They were not going to be exposed by coming out. So I think there are real pockets, and it is only pockets, and policy is the best way to do it. But I don't think we wait until that happens. I think we look to our partners. So this is just, there will be savings across the system as a result of what's happened. In terms of the state, we've seen, there are council services provided in Leeds that are now all operating from home, and at the moment they're being delivered in really high cost accommodation in the city centre. If we can see that people are beginning to move towards other ways of working, there might be more money across systems to do this. So I think we've got to really be part of our local, partnership systems to try to make that whole change happen.
Yeah, I agree with you there, Alyson, because my mileage per month is approximately 150 miles. Over the last 3 months, it's 0. So, that's just, one clinician over, it's a big amount of savings. And also, a lot of the rooms that we hire out to, where they're not NHS buildings, we do have to pay for that as well. So, again, it would be another added cost.
Okay, we actually got a question from Rachel Grant, who is a nurse, and she says, I crave the personal interaction with service users. So I assume she's talking face-to-face, maybe. But working in policy, I see the benefits of technology for continuity of care and progression. How do you think a shift towards technology may impact job satisfaction for staff and the type of people who want to join the profession? I can talk for myself. First of all, I find we need to mix it up. I'm going stir crazy just having telephone clinics. I really do want a hybrid system as soon as possible. Amy, you want to comment about this?
Oh, sorry. Yeah. So yeah, I completely agree with you there, Gavin. I think there is a time and place for video calls and technology, but I do think, like you say, you kind of get swamped with the emails and you kind of focus on one thing, where it definitely needs to be, like, say, a hybrid system, and knowing what works and where to actually put, to do the clinics. We were already talking as a community as to, do we come away from the routine appointments and make the routine appointments telephone or video calls, just to also help the people that we're seeing, because a lot of them have to take half a day's leave from work in order to see us. And do they need to be reminded of that every 3 or 6 months, that that's part of their routine care, where actually we could deliver that routine care a lot differently?
Okay, so I think we're probably going to have to formulate a system where actually collect evidence. So Bernie, this is where your NeuroResponse is so valuable, because you've got built into the NeuroResponse automatic metrics that then generate an evidence base. I don't know if you want to explain how you've taken clinicians out of the UTI loop to manage UTIs and then generate evidence based on reducing hospital admissions. Is that something that we could transfer across this new space into all the other service developments?
Yeah, I mean, I'm hoping, obviously, that is something that we can scale, because basically what we've done is we know from our audits, which you're part of when we look at our region, but we know it's a UK issue, that out-of-hours care is really, really poor for MS or any long-term neuro condition. So if you do develop signs of a UTI or infections or relapses at the weekend or at 10 o'clock on a Saturday night, there's nobody there. So what we have done is we've created an anticipatory care plan. It's just a little summary care plan that is connected to your, when you register, to your mobile phone. And then we have a hub of NHS 111 that we have upskilled. So there's over 50 GPs, paramedics, nurses in there. So it's one hub in London. So when you register in your anticipatory care plan and you ring in at 10 o'clock at night, it just takes you to that hub, and it'll say, and the technology recognizes your number and connects it to your care plan. So the care plan comes up and it says, oh, hi, so you've got a NeuroResponse care plan. In addition to signing the care plan, you have at home your own urinary specimen pots, which are already pre-ordered and QR labeled for you. And that's from a laboratory linked to courier. So imagine you've got a UTI, you're ringing up at 10 o'clock at night. They can see your care plan, you're talking it through. Yes, I think I've got a UTI. You've got a couple of options. You're going to self-monitor. Maybe you need to have an on-call GP to come to your home, or maybe you're really quite sick and you need to go to A&E. So they'll triage that automatically. But for the majority of people, they've picked it up early. They know something's brewing, so they are ready. They've got their specimen there. So the 111 GP will say, fine, I can now dispatch a courier to your home, again 24/7, collect that specimen, bring it through to the lab, start fast tracking that. So then you're working together over the next couple of days. Self-monitoring, to call in if you get worse. Then we get the lab results back. You get the bespoke, antibiotic, and that's emailed out to your local Boots or wherever, and then you pick it up and on you go. And then you have a follow-up call, day 7, how are you? And a similar sort of thing around relapses, in that patients ringing with relapses are again assessed, because we've upskilled this group of GPs, and they can link in either to their GP, or they're linked into the SPR at across London. So they're in with the SPR in Neurology at the Free, or at wherever the patients are linked to. So so we've got evidence that we're reducing presentation to A&E, and of course the other thing that happened for people in our area, when they turn up in A&E with a UTI and had difficulties, they were often admitted into general wards and stay too long and So now we're showing that people are not turning up at that A&E part of the system, and are getting good care, fast care, and bespoke. They're getting on the right antibiotic at the right time and getting better.
Oh, Bernie, can I ask you a question in the interim? Is that model going to be? Is it just for London, or is it starting to
Well, Yeah, it's at the moment it's just for an access only in parts of north central London. But it's like a lot of things, when you're trying to bring innovative new practices, there was barriers in the system.
So what I wanted to say is, if we can encourage everybody in the MS community to do what NeuroResponse has done, is to put built-in metrics to at least record the impact and the efficiency of the system, so that when it comes to maintaining these services, we can create the business cases. And this is probably going to need a lot more deep thinking before we just did this. Alyson, is there any analogy outside of what we're doing in MS where we could do this?
To be honest, I'm not sure I could make that connection, Gavin. I'm not quite sure. No, I don't know.
I mean, so George, would you like to have a relapse service that you could clock in at 7/7, 24/7? Doesn't matter what time of day or night, you can get access to a clinician.
Yeah, I mean, of course. Why wouldn't you want that? Yes, that would be beneficial. And all the questions which in terms of access to health records, and assuming the person at the other end of the phone has access to your information, then in theory, I think it would be a very good thing for people with MS.
Yeah, so maybe this lockdown is going to have spoiled people with MS, because they've probably had access to information sources or access to healthcare professionals in a way they never had before.
One of the things that occurred to me, Gavin, as you were all talking was, and I don't know whether this has happened, is that the fact that when we use the technology, it makes things much simpler. It seems to simplify lots of things. It's whether or not you've tried to do joint consultations. So with other consultants, with other people who would provide support for other aspects of a person's health. So that we don't just present always with one thing. And I wondered if you tried any joint consultations.
Well, I've had in the same room other nurses, but I haven't actually set up joint consultation, because the interesting thing about AccuRx, which is the one I've been using, it's got 4 rooms, so you can invite yourself, the person with the disease, the patient, and you could invite 2 other healthcare professionals. Often the MS nurse comes into the room, our MS nurse, but this is a very good opportunity, because all of a sudden it breaks down those geographic boundaries, and I think that's something we should explore. And it's actually quite nice to see the interaction. What is quite nice is I've had some patients bring in their carers, and so or bring in their parents, and their parents are away, and so all of a sudden you getting a much deeper and a better quality consultation because of that. And I think that does help.
And on that point, Alyson, before pre-COVID, one of the things we were doing as well, if we find people with quite frequent UTIs and needed to be reviewed, I, in my district nursing role with the nurse, would visit the patient with sometimes a GP, the district nurse, their family, and then we would zoom in the urologist and the neurologist and into that bedroom or in something, and that was very, very powerful. And we were able to get really good plans together, because rather than so I do think that there'll be more of that going forward.
So the other thing about platforms, I mean, I don't know how many people are logged in here, but Alyson, one of the things that this provides is all of a sudden the logistics around doing group clinics. So we actually did a pilot group clinic for falls prevention and bone health, and we ran a few pilots. And the reason why it fell apart was actually getting the coordination right. And bringing everybody in together at the same time. Whereas a Zoom meeting, there are no boundaries. So you could actually do a falls prevention, bone health group clinic on Zoom with such a low threshold for doing it. The logistics are sorted out almost immediately. You just have to get people to agree to dial in at a certain time when you can run these clinics. So I think that's something we should explore. Amy, I don't know, is that something you would want to do in Hampshire, is group clinics?
Yeah, definitely. Yeah, I think we've always wanted to work more closely, especially with continence team. And as you said, it's just timings. Everyone's got their own clinics that they're kind of scheduled to anyway. But that would be like really good. But sorry, also going back to the point with the out of hours NeuroResponse, Bernie, could that link to your study that you've done recently, Gavin, with the secondary progressive, feeling that they've had that they're kind of out on the loop at the moment, and like with that technology, could that make them feel more inclusive? And I was just wondering, I just think it's a brilliant service, really.
I'm sure it could make them feel more inclusive. I mean, we know that depending which part of the country you're on, 10, 15, 20, even more % of the actual MS population have fallen through the cracks and are out of the service. So, now if we have these platforms that we put in place, we can bring them back into the service that we didn't have them before. And I think, so in other words, the technology platforms can reduce the hurdles of keeping people in the service. There's no doubt that happens. So Bernie, are your patients, they're all plugged into an MS service? Do you have any patients on NeuroResponse that are outside of an MS service?
Yeah, exactly that. So if you go into like a population health level, and we went into Barnet, where there's 500 people living with MS, we identified 470 from the registers. We have registered about 380 of those from that borough, and that was one of the big things that shocked me, was just the amount. I would say maybe up to 30% had been lost to follow up, and were not under any teams. We're really, and when we were doing the work together in the co-design, there was a real sense of, what do you mean this is for me? No one, I haven't had anything for years, and it was almost like they'd gone from zero to wow, and they had to do a lot of work for people to realize that they didn't matter, and that we were trying to put something in. And then of course we were able to pick things up and then refer them back into the specialist teams and get them all into the right bits. And then a big huge piece was social services and advocacy, and all the issues with poverty and inequalities. So we had to bring in the welfare officers from the MS Society, lots and lots of work. So when you actually go in on foot into in a population health level, you get real life, which is very, very different than what you see in the clinic, in the hospital environment. But you're community based. But so going into that approach, you need to realize that you're opening a can of worms, because there's been a lot of neglect in the system.
So there's Kate. I assume Kate's a nurse by the way she asked the question. I might know you, Kate, so apologies if I'm insulting you for not recognizing your name. Are these not the patients that the community nurses and advanced MS champions should be servicing, whereas the acute trusts are servicing RRMS and those on DMTs? I'd say yes and no. I mean, we don't only service relapsing patients on DMTs, but you're probably right. There are different service models in place across the country. Bernie, those patients you're picking up, are you putting them back into an MS service, or are you just?
Yeah, no, absolutely. So we're doing quite a lot of work, and quite a lot of work in around neurorehabilitation, and then some of the maybe what you call maybe the super specialist clinics, with spasticity and pain, and maybe and neurology. So lots of I mean, the thing that I would say is that what I found shocking was that we have people with very complex needs being looked after by the most generic staff. They were quite well focused staff, but they weren't upskilled by us. So and of course it would be different if those geographies had advanced MS practitioners or community nurses, but the gaps around London are very obvious. And what you found, there was a sort of culture of you see somebody with very severe spasticity and complications, and the team around would say they thought it was just inevitable. So they say, well, that's what happens in MS, and I'm going, no, that's preventable. So so there's this culture that the preventable is inevitable, and so doing all that work to go whoa, that isn't how it should be. We're 2020, you know, and that's, but of course, getting as many people into the right place so that they get treated properly.
Okay, here comes Guy. Hi, Guy. Guy Slade is one of our community-based teams in East London. So he's actually asked the question that we were all discussing before going on. Is about information governance. Does anybody come up with barriers? For example, using Zoom and needing more consent disclaimers. Alyson, is this a generic problem across the NHS?
I mean, I think that it seems like the NHS in different places has made different decisions, and one of the decisions, sadly, has been that Zoom's not safe enough to use, I think, and that's been a decision. And so it's been suggested to us that we use Microsoft Teams. So I think that the fact that people are using different platforms is difficult. But in most places, our experience has been that people have taken the common sense view around whatever will work. And I think it's, you know, it's sharpened what matters to us. And so we've said we're willing to take this risk in terms of making a connection. So I think it's really variable.
Yeah, so I mean, one of the things I did very early on in the pandemic was I started a microsite and to answer questions, and I decided to abandon my principle of not giving personal advice, because the whole problem when we closed down our services was that the MS population couldn't access their nurses or their neurologists because they would be redeployed. And although the MS Society and the MS Trust gave out generic advice, it wasn't suitable for the individuals. So I just started answering individuals' questions around their care because they couldn't get the advice anywhere else. And I just said, well, if I get reported to the GMC for this, I'm just going to say this is an unusual circumstance. These people were desperate to have advice around X, Y, and Z, and I provided it. But also by answering their question, had relevance to everybody else with similar circumstances. So, you know, I think the question and answer session was very popular because it was answering similar questions for other people. So, and I think everybody who asked the questions realized that the platform was designed to share knowledge. That's what it was about. Probably going to have to come to an end now, but anyway. Okay, so no more questions. There's a question from an anonymous viewer. Had there been any national discussions regarding coding for your time, especially joint clinics? If so, how do you record your activity to provide evidence of care? So, Bernie, you got a little experience about who's going to pay for all this. You see, this is the question. How do we code it?
Yes. Yeah, well, obviously, I think that from managing your workload, you have to, it is a clinic, so you should, you know, schedule your diary as a clinic and follow all the governance, if you would, if you were setting up a face-to-face clinic, and, you know, record who attends and who doesn't attend. I think what Gavin's referring to is that one of the situations we're in at the moment is that certainly in secondary care provision, the budgets are already allocated for a lot of activity, which of course isn't going to be happening in the hospital. But these are block contracts, so we're in a new space from April. I mean, it's just unfortunate all the timing, but from April 2020, everything is on a block contract now. So in the old days, it would have been we may have had bespoke, the money followed the volume. So if you did 10 clinics and it cost £100 to see the nurse, you billed for that. But now what's happening in the system is that the secondary care providers are given one lot of money. So say if they're given 10 million as a big trust, that's what they have to use in the year. And they have to decide where they use it in neurology and cancer or wherever. So they've got this one big block contract and then subcontracts underneath that. So that's already happened. And then what we're trying to do, if you think, recently I set up a home phlebotomy service that Gavin's patients are using as well through the NeuroResponse. But, my argument is, well, those individuals would have had to go into the outpatients and would have had to have their appointments and had to have their bloods done there. So can we pull some of that funding out of the system that was allocated and bring that over into the community setting and into innovation? Not so much. It makes sense, but there's perverse incentives in the system. So there's a whole big discussion that has to happen now about that. And I think the only saving grace we will have is that there is a central fund for COVID-19. So if some of this activity can be labeled as supporting that, then there may be some funds, but a massive discussion needs to take place about this new world, because otherwise you're going to have gaps in where the money is.
Yeah, I mean, that's one of the issues. But sometimes the business model around innovation is you do it and the money then comes later. You know what I mean?
Absolutely, which is what I've done with your group. We just do it. But then in saying that was one of the reasons I set up NeuroResponse as a social enterprise, to have the freedom to act. We're nested under the NHS and working in the NHS governance, but we have the freedom to act. So I spoke to my directors and said, this is an issue. These people are being abandoned. Can we do this? We knew we could do it with our partners, because basically we just changed the UTI model. We said, let's give everyone anticipatory of blood monitoring, and let's send a phlebotomist to their homes. And we found a whole group. Our phlebotomists are people who normally look after all the elite athletes on the Olympics. So they were all sitting with no work to do, because there's no athletes performing at the moment. And so they joined our team with the doctor's laboratory. And they've got full PPI. They're hugely professional, because they're top trained. And so now Gavin has a cohort of people on NeuroResponse, and we started within 4 weeks of going into lockdown, and it just automatically, the program will send their date. They'll go to the doctor's lab. The doctor's lab will go to the phlebotomist. The phlebotomist will text you. You'll work out your day and time, and then they're in your home. Do your bloods, comes back. But we sort of just did it.
So let's hope it sticks. That's all. So Agni brings up this question, which is, I think, where NHS governance has gone slightly mad. It's about the fact that we shouldn't be communicating with our patients via email, which is absolutely archaic. Agni, what we do at Bart's Health is we simply get permission to contact patients via email, and they say yes or no verbally in clinic, and we just there's a little field we use to say verbal consent for email contact, and then I think we've got about 70% of our patients who've agreed. Georgia, do you think there'll be anybody with MS who would disagree with being contacted via email?
I'm sure there will be, but I can't understand why they would have problems with it. I agree, it's archaic. It frustrates me when I get letters through from my MS team. I just don't understand it. It doesn't feel efficient use of anyone's time or resources. So I'm a big believer in the use of email.
Yeah, so I think, Alyson, is this something the NHS can do, is create a national NHS email number using the NHS number for individual patients, so that we could at least give them secure emails? Is this impossible?
I think that would never happen, or it would take so long to happen that we wouldn't do it. And I think that what we have to do is think about what would the majority of people want to do, rather than the exceptional cases who say that's not for me. And I think NHS governance always revolves around the exceptional folks, and so everybody loses out. So I think that COVID has taught us to take a more common sense approach around what really must happen. And I think we ask the question about what is it, we ask people that question, but I would imagine the majority of people would find it would make their lives easier as well as your lives easier.
Yeah.
So,
yeah. And Sarah, I'd be happy for whoever's answering that question to link up afterwards, because it's complete nonsense. Well, if a trust is saying that you can't email or you can't, there's lots and lots of NHS governance in place. That's why we all have an NHS app now. You just, it's got 2-factor authentication, where you basically, they'll text you and you go through. That's real in the NHS at the moment. So if it might be an organisational issue, if someone is saying you can't do X, Y, and Z, it may be that they're just not up to speed with the governance of today.
So, I mean, Agni says, people can read your ex-partners can read their partner's emails. Well, they could also probably read their partner's post.
Exactly.
And the fact that faxing is still considered to be fine. I mean, the most unsafe way to communicate with me is via fax, because the fax machine in my building is open to anybody who wants to read anything that comes in. So I think we really do need the governance of the NHS to rethink the email rule, definitely. Okay, there are no more questions there. So, I mean, the question I'm going to ask, Alyson, may I go to you first? Are there any opportunities we're missing at the moment that you think we're missing?
I think that we can, rather than things that are missing, I think there are things that we can definitely build on and make an active step forward. So we talked about the possibilities of things like group consultations. Could we use this opportunity to become more experimental? So group consultations online might be one of them. So we know people want to talk to the clinician, but we also know they want to talk to each other, and we also know how very difficult it is for people to actually physically be in a place. So I would love to see us begin to experiment. We've already started to talk to Klaus about whether or not that might be something that could happen at Bart's in terms of being experimental. I think the other thing is joint consultations, where people have more than one health condition, and that it might really help. And I think the third thing for me is that if we could start from a place where we ask what matters to you, ask that question of people. So we will never come up with a way that works for everybody, and there will be some people who, depending on where they are in the progress of their condition, they need face-to-face, or it serves them better to be able to contact you more regularly from home, rather than have a 5-hour return trip to get in to see a specialist. So I think if we began to ask the question, what matters to you now, rather than assuming that always sticks with them forever, I think that would improve things for people, for patients, for families, and clinicians in the long run, because people are going to be better able to cope, manage and adapt.
George, from a patient perspective, anything we're missing?
Yeah, I don't think missing. I agree with Alyson, everything Alyson said there. I do think that routine appointments, and I stress routine, I think the norm could be over video calls. I think the sooner that happens, the better. I think we need to offer patients, for multiple reasons, the opportunity to have face-to-face appointments. I still very much think they play a role. We've talked about letters today and WhatsApp, and they're miles apart between the two. I think we need to kind of streamline communications and get up to date to 2020. I think appointments, and I know they vary hugely across the UK, but I think it can become more efficient. I know certainly from my personal experience that the communication before appointments, so kind of through surveys that are asked to patients, could be optimized. MS is an opportunity to kind of share what their priority areas are for discussion, and also for healthcare professionals to think about what they would most like to speak to their patients about. I think the time savings that are caused by those efficiencies could perhaps lead to more flexibility with kind of reactive clinics, potentially relapse clinics. I very much agree with Alyson about the kind of social aspect, and I think the kind of collaborative learning is something which we're interested to look into further. So I do think there's a social element, and that's really important, and reducing isolation. But also I think there's a real opportunity for people with the condition to learn from each other and learn together. I think that's something we can do far better. I think at this moment where we're really looking at our services is the right time to think, how can people with the condition help each other? And on that note, I think really understanding how patient empowerment can be prioritised by healthcare systems. What can healthcare professionals do to empower the people who are living with the conditions to play a more active role? I think there's quite a bit of work that could be done there. And again, a frustration that I have personally, but I have monthly blood tests, and I go to my GP, thankfully, to have those tests done. And I've had numerous conversations with both my GP and with my MS team about accessing those results. And there seems, even though I keep banging on different doors, there seems to be no way that those results can be automatically sent to me. And I just don't understand it. And so each month, if I want to get my results, I have to call up my GP and request that they're sent to me. And this just seems balmy. But what we should be doing, I think, is we should be providing patients with as much of the information about their care, and this includes monitoring results, to really empower them to I think self-managed, it's a broad term, but to become more engaged in their healthcare and to be able to understand and spot potential issues further down the line.
Your GP may be able to give you access to your records. I don't know if your GP practice has got that, but some GP practices allow you to access your medical record.
Absolutely, there's a new initiative, George, which is basically every single one of us can get it. It's just the NHS app, and you download it, and your GP will be on it, and then that means everything that's about you at the GP practice becomes yours as well.
Okay.
In about 6 months ago, but it's definitely in place now, and it's going to be the new front door. Digital front door.
That's really positive. I've had similar issues with accessing MRI scans. I mean, it's a broader point that I think it's about the more information that could be shared with the patient about their own healthcare, the more I think that will do to empower people to be proactive, which I think is what we want.
Okay, so we're out of time, so I'm going to let Amy. Amy, you want to sum up and say anything about anything we're missing?
No, I just think this is like the key time to do some audits over the last couple of months and see actually how our service users are valuing the changes or not valuing our changes, so that we can make the right choices from here on in.
Okay, great discussion. Thank you, and it's given me lots of ideas. Have created an AccuRx account and we'll start to use. So AccuRx is the one that basically the GPs are almost all using. I think it's about 80% of GPs are using it. It's embedded in their software. They've got a much better version than we have, but it actually is so easy and intuitive to use. I shouldn't be selling the platform I use, but that's just one of many. There's quite a few platforms that the NHS have given the green light to. It's not just AccuRx, but AccuRx is quite good. Does anybody want to make any other pressing comments before we close?
Could I just make a call for, I think, going forward, that we need to think about the psychosocial burden that's going to come with this, the poverty and the effect on children and families, and make sure that whatever we're doing in our assessment, that we actually spend as much time assessing psychosocial burden as we do on the physical health needs.
Okay, that's a good point. All right, so I just want to say thank you. Thank everybody. Alyson, thank you. It's always nice to have your insights because you come from a completely different perspective to the rest of us. Amy, thank you very much. It's great to have a community-based MS nurse specialist on the panel. Bernie, innovation, and George, Shift.ms, and being a patient perspective. It's very good. And thank you, Sarah, for organizing.